Hello, my name is David Trimberger, and this is attempt number 5, a peer-to-peer direct oral pediatric intubation. First thing that I want to do is gather up all my materials, such as a suction device, the laryngoscope with a couple different size blades set off to the side, an ET tube with a range of about a 3.5 to 4.5 set aside. I want some form of padding, an OPA, a stabilization device, a BVM, and capnography. After I've gathered up all my materials, I'm going to put on proper PPE. Going to come over to my patient, manually open up the airway. If I see any vomitous blood or secretions, I am going to suction out the airway for no longer than 10 seconds, doing a zigzag motion on my way out. I will then come over, re-inspect the airway, measure my OPA, insert my OPA, then I'm going to put a high flow nasal cannula on my patient. I'm also going to connect my BVM to oxygen, connect my patient to a SpO2 monitor, and my goal is I am going to be ventilating my patient for 10 to 12 times a minute, and my goal is to try and pre-oxygenate my patient, meaning that I want to get their SpO2 above 94%. My goal is to 100%. To allow for whenever I am performing my intubation attempt, they have oxygen still going through their system. So after my patient has been pre-oxygenated, I am going to set up for my intubation attempt. So I will take my BVM, go ahead, connect it to capnography, find my stylet, my laryngoscope, going to remove my OPA. I'm going to take my padding and pad behind my pediatric in between their scapula to try and get them into a more ear to sternal line. After I have done that, I will take my laryngoscope, displace the tongue, lift up, insert my tubing to the proper depth, inflate my bubble, remove my syringe, remove my stylet. Then I'm going to connect my BVM to my tubing. As I was doing that, I would be assessing for signs of hypoxia. I'm also going to watch their SpO2, their capnography to make sure that I have proper placement, see if there's misting in the tube. I will continue to ventilate my patient for 10 to 12 times a minute. I am also going to do a secondary confirmation of the tube placement by auscultating over both of the lungs as well as the epigastrum. Once I've done my secondary confirmation, I'm going to stabilize my tubing. Stabilize my tubing, continuing to monitor for hypoxia, watch over their SpO2 monitor as well as capnography, continue to ventilate for 10 to 12 times a minute, monitoring for adequate chest rise and fall, and then monitor for any change in patient condition and route to the hospital. Thank you.